Hello, everybody, and welcome to today's Brain Initiative webinar. My name is Stefan Schoisswohl. I'm a postdoctoral researcher at the University of Regensburg in Germany, and I'm also affiliated with the Bundeswehr University, also in Germany. And I mainly do research in basic science of TMS, so TMS-EEG combinations, for example, but also treatment applications in tinnitus. So not only rTMS, for example, but also all other kinds of treatments we have in tinnitus. And I'm also a co-coordinator of a big EU-wide project called the Unity Project, where we are investigating other kinds of treatments for tinnitus in 5 different centers. So we're doing an RCT. And today I want to talk about brain stimulation, about repetitive transcranial magnetic stimulation as a treatment in tinnitus. And of course, I want to first start with a little bit of a background about tinnitus. I hope you can see the next slide because we had some troubles switching the slides, but I think everything is okay. Otherwise, there will
Stefan,
be...
it's working well. One last thing I forgot to mention before you go: if anyone has any questions at any point, you'll see you've got a little question mark Q&A thing at the bottom. Feel free to type your questions in there, and then when Stefan's finished at the end, we'll put the questions to him then. Okay, Stefan,
Perfect.
all yours.
Thank you very much. So just wanted to start with a little bit of background or basics about tinnitus. So tinnitus is defined as the conscious awareness of a tonal or composite noise for which there is no identifiable corresponding external acoustic source. So tinnitus can be ringing, it can be hissing, can be buzzing, it can be experienced on one ear, on both ears, but also within the head of tinnitus sufferers. And common causes are, for example, cochlear damages after noise trauma or after the usage of ototoxic medication. And a particular cause is hearing loss. And in fact, 80% of tinnitus sufferers have a certain degree of hearing loss. And if tinnitus, or how we call it, auditory phantom sound perception, is present over a period of more than 6 months, tinnitus is defined as chronic. And globally, 14.4% of people experience tinnitus. So that's more than 740 million people worldwide. And in 2% of which tinnitus represents a severe burden. And once tinnitus gets associated with emotional distress or cognitive dysfunctioning, tinnitus evolves to so-called tinnitus disorder, and we have many comorbidities which come along with tinnitus, like depression, anxiety disorder. People have troubles with their sleep, they experience hyperacusis or report a general reduced quality of life. And we also have a wide variety of phenotypes and etiologies in tinnitus. So we call it in tinnitus research tinnitus heterogeneity. So far, tinnitus is still a scientific or clinical enigma so far. And in the generation or in the emergence and maintenance of tinnitus, we know that peripheral and central mechanisms are equally involved. For example, it is assumed that the reduced auditory input, so because of the hearing loss from the periphery, so reduced input from the periphery leads to a lack of neural input into the auditory pathway, and this in turn provokes then maladaptive neuropathological or neuroplastic changes in the central nervous system. And these mechanisms are assumed to be responsible for the perception of tinnitus. So the brain more or less tries to compensate for this loss of signal it gets from the periphery, and that's the tinnitus people are experiencing. And some pathological changes are, for example, an abnormal neural synchronicity along the auditory pathway. We also observed an reorganization of the tonotopic map of the auditory cortex, and also that auditory brain areas are hyperactive, for example, and that pathological alterations associated with tinnitus do not only occur in auditory-related brain areas, but also in other parts of the brain. And it was suggested that these pathological neural circumstances represent a significant leverage point for neuromodulation techniques like, for example, transcranial electrical stimulation or transcranial magnetic stimulation. And for example, if you're interested in electrical stimulation, my colleague Laura Shakim already talked about TDCS as a treatment for chronic tinnitus, and I think this is still available on the YouTube channel from the Brainbox initiative. But today's focus of the webinar is about transcranial magnetic stimulation and tinnitus, and I think many of you are familiar with TMS, but of course I want to start with a little bit of a primer about TMS. It is considered a safe and well-tolerated brain stimulation technique and is based on the principle of electromagnetic induction. So their short electrical currents are going through a coil which is placed over the head, and this generates a magnetic field, and this field passes through the cranial bone and generates there an electrical field which is able to depolarize neurons which are under the coil. And simply we can induce action potentials when we stimulate with a certain intensity, for example. And if, for example, single pulses are applied over the left motor cortex, we are able to experience or observe peripheral muscle responses, for example, here on the hand muscle of the right hand, which are called motor evoked potentials, and those are typically used as a marker for cortical excitation. And besides single pulses, rTMS can also be, or TMS can be used in a rhythmical manner, for example, at 1 Hertz or 10 Hertz, for example. And there is this heuristic that low frequency rTMS acts inhibitory and that high frequency rTMS acts excitatory. And there are also other patterned rTMS protocols like continuous theta burst stimulation. For CTPS, there are triplets of pulses applied at 50 Hertz. So every 200 milliseconds, triplet of pulse is applied. And CTPS is said to be inhibitory. And on the other hand, there's also ITBS, so intermittent theta burst stimulation, which is said to have excitatory effects. And we also know from research that with single rTMS sessions, we can induce effects up to 2 hours. And if we apply rTMS in a daily manner, we can induce long-lasting neuroplastic effects or therapeutic effects. And of course, therapeutic effects, that's what we are aiming for when we apply rTMS in tinnitus. So already 20 years ago, rTMS was introduced, or especially low-frequency rTMS was introduced to reduce this hyperactivity, overactivation, which was observed in the left temporal cortex, for example. And this led to the protocol, which is nowadays also still used as the most common protocol for tinnitus, which is 1 Hertz rTMS over the left temporal cortex. A typical treatment involves 10 sessions over 5 workdays and 2 weeks, and patients typically receive 2,000 pulses per session. And in this regard, or since that time, over 20 years, there are over 60 studies published and conducted so far, and there are also 2 large scale randomized clinical trials conducted in this regard for low frequency rTMS in tinnitus. One was from Landgrebe et al. 2017 and one from Vollmer et al. And I wanted to show you the results of those big studies. So one was from Vollmer et al. They conducted a randomized double-blinded parallel group placebo-controlled clinical trial with 64 patients and compared active rTMS over the temporal cortex against a sham stimulation, and they observed that tinnitus distress, so maybe tinnitus distress is usually measured with specific questionnaires like the tinnitus functional index or the tinnitus handicap inventory, and they observed that tinnitus distress decreased at all time points for the active stimulation, and they also observed that there are more responders in the active stimulation group than in the sham stimulation group. And these improvements in the responder group were also sustained during the follow-up phase. So the conclusion from the study from Vollmer et al. that rTMS might be effective as a treatment option for tinnitus. And then there's another study from Landgrebe et al. They used approximately the same methodological approaches. It was also randomized. It was only single-blinded, but it was multi-center, and they investigated way more patients. They investigated 146 patients, and also compared active against sham stimulations. And they observed no changes in active and sham rTMS compared to baseline. And they also did not observe any differences between an active and a sham stimulation. And so from this study, the conclusion which can be made from this study is that there is no therapeutic effect or no therapeutic benefit of rTMS for tinnitus. And on the next slide, you can see some differences between both studies. So, for example, the former study was only single center and the Landgren was multi-center. They had a little bit difference in the sample size and the mean age. And maybe a crucial point for the differences might be that the former study stimulated left or right temporal cortex, whereas the Landgren study only used the left side for a stimulation. And another very critical point is, which I will mention later in my presentation today, is that they used two different TMS devices. That's very, very interesting. And they also used two different outcome measures. So there are some slight differences which might be responsible for this. So we have two big RCTs with different findings and with respect to low frequency rTMS, but what's happening beyond left temporal low frequency stimulation in tinnitus. So there are also studies which use more novel protocols like the theta burst stimulation, continuous theta burst stimulation, which is said to be inhibitory. There's one study from Forok et al. They showed that a burst stimulation is superior to a standard tonic rTMS stimulation. As you can see here, for example, we have a superior decrease from baseline to after treatment, and also during follow-up phase, there's this difference between those two protocols. And there's another study from Scheckelmann et al. From our team in Regensburg, who used CTBS in combination with a neural navigation system, and they were not able to show any superiority of an active CTBS stimulation compared to a sham stimulation, for example. And in a more recent review from Schwippel et al., they also concluded that currently there is no sufficient evidence of CTBS for its application in tinnitus. So it's almost like low frequency stimulation. So what other people did then, based on the assumption that not only the auditory cortex or that pathological tinnitus associated alterations do not only occur in the auditory cortex, but also in other regions, for example, the frontal cortex. People also started with prefrontal stimulations and also used high frequency stimulations, which are, for example, used in depression studies, or which is a common protocol which is used in depression in order to counteract the hypoactivity of the left DLPFC, for example. And what Theta, for example, and colleagues showed that low and high frequency stimulation is superior to a sham stimulation, but the high frequency stimulation, interestingly, performed better than the low frequency stimulation. And other studies even went one step further and combined prefrontal and temporal cortex TMS. So, for example, there's a study from Lena et al. 2016. They did a triple side stimulation. So they stimulated the left DLPFC with 20 hertz and the left and right temporal cortex with low frequency stimulation. And as you can see here, they compared it to a single side stimulation of the temporal cortex, and they did so directly after treatment. They did not observe any superiority of this triple side stimulation. Both performed better than sham, but during the follow-up phase, the triple side stimulation was superior to the single side stimulation, maybe because the DLPFC was targeted and effects might last longer. We account for or want to counteract depressive symptoms in tinnitus and not only the auditory cortex to change the tinnitus percept. Another study from No et al. Also compared dual side and auditory only stimulations. They also showed that a sham stimulation, or that both verum stimulations are better than sham, and that the auditory performed better than both and significantly better than the sham stimulation. There's another study which is very interesting because they could show that only people who have tinnitus and depressive symptoms showed a superior improvement in dual side stimulation if the DLPFC and the temporal cortex are targeted. And people who only report tinnitus, they did not show this this steep increase in symptom improvement like the people with tinnitus and depression. It's very interesting. It could also be in line a little bit with the findings from Lena et al. They also used left field PFC stimulation. In a recent study we did in Regensburg, for example, which is under preparation now, we used ITBS, excitatory protocol, typically used in or has promising results in depression, based on the assumption, as I said before, that there are overlaps between tinnitus and depression, and that changes, pathological changes also occur in frontal regions. In tinnitus, we targeted the left DLPFC in order to improve effective and cognitive control over symptom distress, and we could show that from pre to post treatment, tinnitus distress decreased, and also that depressive symptoms in those tinnitus patients also decreased with this intermittent theta burst stimulation protocol, and that the change in tinnitus distress and the change in depressivity with the MDI is also correlated. And we also could show that people who reported their tinnitus distress as catastrophic, or the number or the quantity of people who reported as catastrophic decreased, and that the number of people who reported their tinnitus distress as mild increased, for example. So we have a little bit of a change here, which is visualized here via this Sankey plot. Okay, then other studies did very interesting things. They combined medication with rTMS, for example, or even used peripheral muscle stimulations in combination with rTMS. So you can try many different things. And for example, the study from Kreuz et al., they also used relaxation techniques in combination with rTMS, and they could show that the number of treatment responders was higher in the relaxation group than in the active control group, and also higher as in the placebo control group, for example. So many different things are tried, many different stimulation parameters, different approaches and different studies, but is rTMS general effective for treatment in tinnitus? And there are many different meta-analyses and reviews conducted, as you can see here. Some or earlier ones state that there's a convincing body of evidence for rTMS as a treatment option. Others say there's only limited support, or it could be a therapeutic tool. Others say there's some evidence and it has medium to high effect size. A newer one says that it's not recommendable, and even more newer ones say that there's a potential efficacy. And I'm also sure many of you are aware of the paper from Pascal Lefaucheur, and they state that rTMS has a level C recommendation for its application in tinnitus, which states that there is a possible efficacy. And a recent study stated that rTMS is especially effective in tinnitus when it's applied over the auditory cortex. And there's another recent review from this year, 2023, from Watson et al. It's not on the list here. They performed a review and screened over 1,000 studies in tinnitus with rTMS in order to find the optimal target which can be used for tinnitus. And their conclusion was that the temporoparietal junction is the best position, or the optimal position, for rTMS treatments in tinnitus. So that's very interesting. So potential reasons why we have those different results and have no clear conclusion about rTMS in tinnitus. So we have inter-individual treatment responses, of course, and we're not sure which technical parameters are the right ones for tinnitus. So in general, in rTMS research, we have many technical degrees of freedom. We have different stimulation frequencies, how many pulses are needed, how many of them are needed per session, which is the right position. Current direction is also a very important parameter, as well as pulse form and so on. And in tinnitus, it's not quite sure which ones are the right one. And that's why we performed systematic review to identify parameters which are responsible or which are most suitable for tinnitus rTMS applications. And we found out that lower stimulation intensities, as well as a lower number of pulses per session, is associated with significant effects of active rTMS. And we also found out that an additional DLPFC stimulation was not found to promote its efficacy, which is maybe in line with the study from from which I mentioned previously. I think it was Triple. Yeah. And in general, we found out that verum rTMS of the auditory cortex is superior to a sham stimulation, which is indicated by the proportion of significant pre-post contrast, for example. And another reason why is, of course, we need to consider subject-related factors like the brain state prior stimulation, which is shown to be relevant, and of course, which next important thing is that the brain and the technique interact, and we know that the tinnitus brain is already pathologically altered, which might, so we have a different intrinsic state in the tinnitus brain than the normal brain, for which usual rTMS effects are investigated. So the brain state or the intrinsic state of the tinnitus brain is already pathologically altered. So a potential way to overcome all this unclarity about technical parameters, as well as the individual brain state of tinnitus patients, might be the personalization of rTMS for tinnitus. And it was already suggested in general that personalization of treatments or individual treatment schedules might be a solution to account for the tinnitus heterogeneity I told you before, and also to account for the variability we have in treatment effects in tinnitus, so in general for tinnitus. And with respect to rTMS, we know that it is feasible to shortly suppress or diminish the tinnitus preset with single rTMS sessions and only a modest amount of pulses. And we can use this information. So our idea was this in Regensburg, to use this information about short changes in the tinnitus percept after a brief intervention, to use this for a daily treatment application, as you can see here. And for example, you can do this via so-called test sessions, where you can test several different rTMS parameters like frequency, or if you want, intensity and so on, with respect to the ability of this protocol in brief tinnitus suppression. And this information can then be used for a daily treatment. And we investigated this concept of rTMS personalization via test sessions in many studies in Regensburg, or in some studies in Regensburg, and we found out that it's possible to do this via this test sessions. And for example, in one study, we stimulated with several different frequencies, so 1 Hertz, 10 Hertz, 20 Hertz rTMS, and we also used the sham stimulation, which was 0.1 Hertz. So this protocol is assumed to not induce neuroplastic consequences. That's why we used it, because of the high interpulse interval. And we also used two different, we also stimulated on both hemisphere over the temporoparietal junction, for example. And patients were requested to rate the loudness of the tinnitus before and after each protocol. And this whole procedure was repeated on a second day to test for reliability. And our criteria for rTMS personalization was, or which was a responder criteria, was that the mean loudness suppression of the specific protocol should be superior to a sham stimulation. This should be reliable, so on both test session days for the same rTMS protocol, as well as for the same stimulated hemisphere. And with this relatively strict criterion, you have to imagine that it has to be present over 3 minutes. We ask them every 30 seconds over 3 minutes, and it needs to be superior to a sham, and it needs to be reliable for the same protocol. And even with this strict criteria, we're able to report that in 55% of patients, it's able to personalize rTMS. And interestingly, most of the people respond to high frequency stimulations. So this is very interesting. But with respect to small sample size and the early stage of those personalization approaches, and maybe also due to our very strict responder criteria, there's so far no statistical superiority of this personalized rTMS approach. So we can only report descriptive superiority, for example, with respect to tinnitus unpleasantness, which shows that personalized rTMS is superior in decreasing tinnitus-related unpleasantness compared to standard rTMS protocol, which was here also 1 Hertz, for example. So we also tried other things in Regensburg. So I want to show you 2 studies now, which we conducted with some very interesting ideas. And one was one way, or we called it one way or another. And as I told you before, we had those two RCTs with different results using two different TMS devices. And we got in contact with the TMS manufacturers, and they told us that even if we use the same stimulation position and orientation of the coil, those two devices differ in their induced current direction by default. So this might be also a very interesting or crucial factor, which might be responsible for the incongruency of Landgrebe and of the study from Landgrebe and the one and the RCT from Vollmet Island. That's why we conducted a small study where we stimulated with two different current directions of 1 Hz rTMS over the temporal cortex. We used biphasic pulses. One current direction was from anterior posterior to posterior anterior direction, and the other one was posterior anterior direction. And we were able to show that, interestingly, the posterior anterior biphasic current direction, the posterior anterior posterior current direction performed or was superior in decreasing tinnitus distress and depressive symptoms, as well as loudness, ignorability, and unpleasantness in this study. And it was only in a small study. That's why we also did some sample size calculations. It was more or less some kind of feasibility study or a pilot study to see if there are any differences. And interestingly, even with this small study, we were able to show some interesting effects, even if they are not significant. And the interesting thing is that the current direction was the same, so the posterior anterior current direction was the same as it's used in the literature for chronic pain, for example. There's also this current direction which shows the best results. And we also know that pain and tinnitus share some similar mechanisms, for example. So this is also very important for future studies to consider, I think, the parameter current direction, which was in past research totally neglected. In another study in Regensburg, a small study, we call it Activate and Fire. It's also a very interesting concept based on the premise that rTMS effects are state dependent. We know this from past research. There's an interesting study which showed that a sound stimulation before low frequency rTMS is able to shift its effects. It was from Weiss et al. 2012. We have this nice title formerly known as inhibitory, and this might since rTMS effects are state dependent, it might be possible that rTMS effects reverse or transfer from inhibitory to excitatory in the tinnitus brain, because the tinnitus brain is already pathologically altered. And this was also shown by Weiss et al., for example, that in tinnitus, we see that there's diminished activity in the alpha frequency range, and that there's enhanced activity in the gamma frequency range, which is not visible here, but you have to trust me that tinnitus patients have lower alpha and higher gamma activity compared to controls. And it was also shown in tinnitus research that with short acoustic stimulations, we can induce short-term tinnitus suppressions, which is termed residual inhibition. And this phenomenon can be induced in 60 to 80% of tinnitus sufferers. And we were also able to show that during this brief suppression, we see a short inversion of this pathologically altered brain activity we have in tinnitus. So for example, if the tinnitus is suppressed or decreased, the tinnitus perceptus decreased, we see that people who experience this, the alpha activity goes up and the gamma activity goes down. And this difference in the alpha activity was also source localized in auditory, cortical, or in auditory related areas. And this information or this insight lead to the idea that we can apply acoustic simulation prior to rTMS and theoretically shift the brain activity of tinnitus patients back to normal state. And with this, we could facilitate rTMS heuristic conform effects, for example, that inhibitory is inhibitory and excitatory is excitatory. And we used CTBS stimulation for this, so an inhibitory protocol, and applied it on 10 treatment sessions. And before each CTBS application, we used 3 minutes of white noise. So this was 3 minutes of white noise and then CTPS. We also screened patients with respect to the ability to induce residual inhibition in them. So they were only included in the study if this phenomenon was inducible by them in the screening procedure. And this was also relatively small sample size. So it's just to test the concept and see how it works and to see if we can find something and how big the sample size should be for future studies to investigate it properly. But even with the small sample size, we were able to show that in contrast to 1 Hz rTMS, the activate and fire stimulation was able to superiorly decrease tinnitus distress, but also tinnitus loudness, for example, as you can see, unpleasantness, and that during the follow-up phase, depressive symptoms, or there were significant differences between the depressive symptoms between the activate and fire group and the 1 Hz rTMS group. So this might also be worthwhile, besides current direction, to investigate in further studies with bigger sample sizes, for example. Okay, then some final remarks from my side. So taken together, we have heterogeneous findings of different studies using very different approaches, using different protocols, parameters. We have different findings of 2 large-scale randomized clinical trials, for example, and there are many different meta-analyses conducted and reviews which also show different findings. And in general, we observe a high inter-individual variability in treatment responses when we use rTMS for tinnitus. So taken together, the clinical effectiveness of rTMS is still not obvious. We need to, of course, do more investigations, and we also need to identify which protocol or which parameters are the right ones for an application in tinnitus. So since AI is very popular so far and people use ChatGPT for many different things, I asked ChatGPT which rTMS protocol works best as a treatment for tinnitus, just for fun. And the response was more or less what I tried to present here during this webinar. So now you should know that there's no consensus of the most effective treatment approach for tinnitus and not for rTMS. We have many different approaches. We have auditory stimulations, we have frontal stimulations, we have high and low frequency stimulations, and rTMS is still not yet considered as standard therapy, but in general in tinnitus we have no overall treatment. The treatment of choice is still cognitive behavioral therapy, for example. And I also showed you some new concepts. So new rTMS protocols are developed, and they maybe offer even greater benefits for those people who struggle with tinnitus. And they also covered this by the personalization of rTMS. So tailored treatments are very important to adjust protocols or treatments based on the individual needs and preferences. So ChatGPT covers almost all the things I wanted to show you during this webinar. Very interesting. So how to continue? As I said before, we need to identify which parameters are the best for a treatment in tinnitus. It's not like in depression where we know, okay, left DLPFC, high frequency stimulations are the way to go. We're not so far in tinnitus, maybe in the future. I think personalization of protocols is the way to go and should be investigated in more detail, and also not with that strict criterions we had in our studies so far, as well as bigger sample sizes, and also interactions, of course, of different parameters need to be considered. And another thing we have in tinnitus, since tinnitus is a subjective phenomenon, the identification of a neurophysiological marker might also provide more information or a specific target we can use for rTMS. But still, there's no clear evidence or no clear correlation about from neural and behavioral data available. And other approaches are, for example, the identification of predictors for rTMS response. So there's a study from Lehn et al. They did not observe any demographic or clinical predictors. There's an interesting study from Pöppel et al. They found that distinct anatomical brain patterns are able to predict rTMS responses. And there's also a recent study which showed that higher functional network connectivity between right frontal and parietal regions. So the salience network is responsible for rTMS response. So to sum it up, not much is understood. We need way more investigations in this regard. I think in tinnitus research, not only for rTMS, we're still at the beginning. We can try many different things. Tinnitus can also act as a model, for example, to test parameters or different novel treatment applications, because we have this immediate response after stimulation, for example, in the tinnitus percept. And I think not only in tinnitus groundwork is needed, but also in general, we need to do more groundwork, for example, with respect to the technical parameters in tinnitus. And I want to do a little bit of an excursus, because I'm also part of the MAX project, where we investigate several different technical parameters on the healthy motor cortex. And there are two PhD students, Mirja Osnabrügge and Carolina Karnik, who are working on those things in Munich and Regensburg. And they will also have a Brainbox webinar very soon, where they talk about the reliability of motor evoked potentials, as well as the reliability of neuromodulatory rTMS effects on the motor cortex. So I'm looking forward to this. So if you are interested in some further reading about brain stimulation general and tinnitus, I only can highly recommend you the work from Bertolt Langgut and Dirk de Ridder, which are big names in the field of tinnitus. And just as a recommendation, if you want to read a little bit more. And I think I tried to cover many things, but there's so many things happening, I cannot cover everything. So maybe this further reading gives you some details you are searching for. And I hope I could give you a nice overview of rTMS and tinnitus, and want to thank you for your attention, and also thank you to the Brainbox initiative to make this webinar happen here today. Thank you very much. And I stop my screen sharing.
Cool. Thanks, Stefan. Very interesting. Also scary how accurate the AI response is as well. You know, maybe I should start to be worried.
Maybe I should only have shown this to you, and then we would already have covered everything. In
would have been a very it would have been a very short webinar, perhaps not quite as engaging. So there's been a couple of questions rolled in over the duration. I don't know if they're going to mean screen sharing again, but feel free if you want to go back to certain slides and whatnot, then you're welcome to. I've also got a question I might ask as well. Okay, so the first question from Stephen Hopkins. I don't know if it's a question or a comment, but has a 44-year-old patient with chronic tinnitus who tried the active noise cancelling headset, and the tinnitus vanished, but it came back when the noise cancellation was turned off. Is that a common phenomenon, or?
I think this has something to do with amplification, and we give the brain input, which was not there before. And if you put or start this input, then tinnitus can decrease or go away for a certain amount of time. And when you switch it off, then it often comes back. But I cannot make a general statement, because that's so different for each patient. It's so heterogeneous. And as I said, in some patients, some things work. We have patients where we used acoustic stimulation, for example. We induced residual inhibition. And then the tinnitus was, for example, for one patient out of 70 something was completely gone. And in others, for example, the tinnitus increased. So it's if you're a patient and searching for help or cure, I think you have to first try many different things, but I can only recommend to you to seek professional help, and also try CBT, so cognitive behavioral therapy, to try to learn to live with your tinnitus, and to realize that the tinnitus is not going away. It is part of your daily life, and you should accept that and try to deal with it and move your thoughts somewhere else, and not only focus on your tinnitus.
Cool. Okay, second question from Henning, who's also just posted a second question from him, a fourth question overall. So you potentially touched on covering this in the slides towards the end, but blinding participants, as we know, is particularly hard with TMS. Are you aware of any studies that observe the effectiveness when peripheral sensations are controlled for example, vertex stimuli or use of placebo coils, which mimic peripheral effects of TMS?
So not with tinnitus actually, but I think that's a general problem we have in brain stimulation to do placebo stimulations or sham stimulations. And I think there are some people, I think it was Gordon, I think there was also a Brainbox webinar about it, about sham stimulations in general with TMS. And people are working pretty hard to develop mimical stimulation so we can have proper placebos. Yeah. So for example, we used in the study I mentioned 0.1 hertz stimulation as a sham because we did not want it to change the orientation, because then you do not have the sensation on the scalp, so nothing is happening. Other people try to mimic it with electrical stimulation and so on, but that's a general problem. I do not have a right answer here.
Yeah, in terms of sham as a solution, it is something that the community is working on, and it is we have sham coils available.
Yeah.
There is a paper that I will try and root out on sham coils, and I'll drop it in the chat if anyone is interested in having a look. Assuming there is a chat on this, I'll find it somewhere and someone can share it. Okay, so question number 3. How is the target in the brain for rTMS typically chosen for tinnitus? Is it also personalized to the individual patient somehow? Because we can imagine that the source of tinnitus in the brain could also vary substantially between subjects, which could contribute to the heterogeneity of treatment results.
Yeah, that's right. So the original plan or the first target came up from auditory hallucinations. So this was the temporoparietal junction. So people started doing this, and then my boss, more or less, Bertolt Lango, developed a new position and a new coil orientation and so on. And many different stimulations were fine. And I totally agree with the thing that for each patient, it doesn't have to be the same, the position. And we also did, I did not mention it here, we did another short study where we used 3 different positions of the superior temporal gyrus, so anterior, middle, and posterior stimulations. And then we used many different kinds of frequencies stimulated there and tried to identify a specific position and also a specific frequency on both hemispheres, for example. So of course you can use many different positions, or an idea I had to use resting state fMRI and identify per subject an individual auditory hotspot and use this as a target for brain stimulation. But then COVID came and we did not realize it, and we didn't have it done yet. And also with respect to upcoming more newer technologies like cobots and so on, we can use grids over the auditory cortex, for example, and stimulate over all those points in the grid and identify also a point which is suitable best for a therapeutic target. But that's always, it needs to be thought of that tinnitus is a subjective phenomenon, and sometimes it's also really difficult for people to evaluate those short changes, which are sometimes very small. So we are still at the beginning, I have to say. We can try so many different things. And another idea could be, because we have this phenomenon, I told you, residual inhibition. So acoustic stimulation, which is able to reduce the tinnitus percept or diminish it in 60 to 80% of people. And we can also, for example, record EEG, induce residual inhibition, do some source localization, and see where for the individual target this tinnitus suppression took place, and use this as a target, for example, for treatment. So there are many different ways, but as you know, in the clinic, doesn't work because of time. In the research context, it's already difficult.
Yeah, lots of things to consider. So another one from Henning. The questions are kind of rolling in as we're going through them as well. So I'll try and rattle through them. Okay. We're surprised to hear about the meta-analytic you reported that less stimulation intensity and fewer pulses are associated with better clinical outcomes in tinnitus. Was this like something you're expecting, as the reverse or the inverse seems to be true for depression?
So I think for depression, there's a dose-response relationship with some studies. And with respect to the finding we had in tinnitus with the low intensity, could be the case because we are defining the stimulation intensity with respect to the resting motor threshold, and which is done over the motor cortex, of course. And then we have a threshold which should represent cortical excitability of all the brain areas we want to stimulate. But actually, maybe we need an excitability measure of the auditory cortex. And if we define the intensity based on motor cortex stimulations where the bone is relatively thicker, we need higher stimulation than we need, for example, for the auditory cortex where the cranial bone is thinner. And this might result in some overstimulation and the effects reverse, for example. And if you already use 80% RMT, maybe that's already enough for auditory cortex stimulation.
Okay, so a nice segue from that then into the next question is that how have you arrived at that intensity for tinnitus treatment? Have e-field simulations already arrived for the tinnitus field, or like where did a percentage of threshold come from?
I have actually no idea. So most of the people use 110% resting motor thresholds, but there are also studies who used 80 or 120. So
yeah,
there's no consensus on this. And we tried, we did a study with the Nextim device, where you have those live e-field modeling and so on. And we checked that we have enough, or I think it was 60 volts per meter or something. Can't remember it. So we took a look on how much of the e-field is really coming to the auditory cortex, but with respect to stimulation intensity, I have no idea. So I cannot answer this question. How did the depression treatment came up with their intensity they used? I also don't know.
Good question. Yeah, good question, and I am not the person to answer it.
I also don't know it. Sorry.
So Philip, Philip Kunk maybe is the surname, has put a paper in the questions thing that I don't think delegates can see the questions, which is a little bit of a shame. We'll try and send these papers out.
Okay, please. Yeah.
We recently showed using e-field simulations that typical dosing approaches based on the motor threshold can lead to massive variability of cortical stimulation intensities, both within and across subjects. And there is a paper there that, yeah, we'll try and share with the group. Okay, two questions, and then we're going to wrap up because we're rapidly approaching the hour. Question number one: is there any strong evidence on whether simultaneous stimulation of several cortical areas is superior to only one for tinnitus suppression?
This was part of the slides, and from my point of view or my understanding, not really.
Nice. Okay, a nice succinct answer. And then finally from Flavio in Brazil. Hello, Flavio. Good to see you here again. Have you considered work with different TMS widths or pulse shapes, or having that next device would be a perfect candidate?
Exactly, yeah. So over the next project, we're working on such things, but we're also trying to do it in fundamental science. So the thing I mentioned at the end with the base or the motor cortical stimulation. So we recently bought a cTMS device, and we also got an ethical approval here in Germany. And now we can try some things, but first we will start in a basic science context and not directly go to tinnitus, I have to say, because with patients this might be a little bit more difficult than with healthy subjects. So in the near future, our PhD student Mire Osnabrügge will do a study on this, and we will see how different pulse widths work.
Perfect. Yeah, cool. Okay, that'll be it for the questions. Stefan, thanks again. Really good and really nice, clear answers to all the questions as well.